Hi, my name is Maria Ahmad. I'm a fourth year medical student at Barts in London, and today I'd like to talk about interpreting arterial blood gases, or ABGs. This is a really important topic, not just for exams, but also for clinical medicine, and in particular acute medicine, which is why I'd like to cover this topic today with some worked examples. In this short talk, I'm going to cover three key questions. Firstly, it's important for us to know what an ABG is and why we do them. We'll then discuss an approach to interpreting ABGs, and finally we'll discuss what the results actually mean and how we can relate it to the specific patient in front of us. So the first question we need to ask ourselves is, what is an ABG? So an ABG is a sample of blood from an artery, and it's typically from the radial artery, to analyse a number of constituents in the blood. And when you're next on the wards, make sure that you have a look at a printout to see all the things that an ABG can measure. So some of the key things are the pH. So the pH, as I'm sure you know, is a measure of the hydrogen ion concentration in the blood, and that determines how acidic or alkaline the blood is. And that's really important because the body needs to keep the pH in a narrow range to prevent enzymes and proteins denaturing and not working properly. The PaO2 is the pressure of oxygen in the arterial blood. The PaCO2 is the pressure of carbon dioxide in the arterial blood, and the HCO3- is the bicarbonate, and that's an indication of the metabolic balance within the body. You can also get things like lactate and some of the other ions in the blood on an ABG. It's important to note, however, that you can also do a VBG or a venous blood gas and get a lot of this information. So ABGs are typically done if you're concerned about a respiratory problem, and in a moment we'll talk about some of the indications for an ABG. So as you can see in this picture here, you go into the radial artery and get a sample of blood. I won't be discussing the exact procedure in detail today, but I'll be focusing on the interpretation of the arterial blood gas once you've obtained it. So these are some of the indications for an ABG. So firstly, low oxygen saturations. So this can be less than 92% oxygen saturations on air, but also it can be low oxygen saturations if they're already on high flow oxygen, because they may have an inappropriately low saturation despite being given a high concentration of oxygen, in which case we need to determine why this might be happening. ABGs can also be used to assess and monitor the acid-base status and any respiratory or metabolic derangements, and we'll talk more about this. And also, ABGs are often used for critically unwell patients, for example, if we're unsure why the patient's so unwell, because they can give lots of useful information. So before we talk about interpreting arterial blood gases, it's important for us to know what the normal values are. So firstly, the pH. So we mentioned that the pH is the concentration of hydrogen ions in the blood, and that it's very important to maintain it in a narrow range. And the normal pH on an ABG is between 7.35 and 7.45. A low pH, less than 7.35, means the patient is acidotic, and a high pH, more than 7.45, means the patient is alkalotic. And this is key to interpreting arterial blood gases. PaCO2, or partial pressure of CO2, is a constituent within the blood that actually provides acidity. So if you remember back to your chemistry days, if you dissolve CO2 in water, you get carbonic acid, and that's an acid. Therefore, PaCO2 provides acidity, which is why it's red on this slide. Another constituent that we measure on the ABG is the bicarbonate, or the HCO3-, and this is alkaline, or provides alkalinity, which is why it's blue on this slide. We also measure the partial pressure of oxygen, or PaO2, which is between 11 to 14 kilopascals normally. It's generally accepted that if the PaO2 is less than 8, then the patient is hypoxic. And finally, we also measure lactate, which is a measure of the amount of lactic acid in the body, which indicates the amount of anaerobic respiration, and is normally between 0.4 to 1.5 millimoles per litre. So let's talk through an approach to interpreting arterial blood gases. So the first thing that we want to look at is the pH, and this helps us determine if the patient's acidotic, so the pH is low, if the patient is alkalotic, where the pH is high, above 7.45, or if the pH is normal. We then want to look at the PaCO2 and the bicarbonate and work out which one matches with the pH. And what I mean by this will become clearer when we work through the worked examples on the next few slides. So if the PCO2 matches the pH, it suggests a respiratory cause, because the carbon dioxide levels in the body are controlled mainly through inspiration and expiration. Similarly, if the bicarbonate matches the pH, it suggests a metabolic cause, because the bicarbonate levels are controlled by the kidneys. The one that doesn't match indicates compensation, or that it's not the primary cause. Again, this will become clearer when I talk through the worked examples. But the reason that the body has compensatory measures is because we said it's important to maintain the pH in a narrow range. So the body has lots of ways to deal with a pH that's too high or too low. So there's respiratory compensation, and that acts quickly within minutes. There's metabolic compensation, and that takes a few hours to work because it involves the kidneys. It tends to be that a metabolic problem has respiratory compensation. Because the metabolic system is deranged, not working normally, it means that the respiratory system has to compensate or deal with that. And vice versa, a respiratory problem tends to have a metabolic compensation. Note, however, that there's not always compensation, particularly if the problem is acute, so some values may be normal. So let's put this approach into practice using some examples. I've related these examples to patient scenarios, and as well as the interpretation of the blood gas, there's a hidden diagnosis for each example that relates to the blood gas, so see if you can work out both. If you've interpreted ABGs before, I'd recommend pausing the video to try to work out the type of blood gas and any potential diagnoses. So we're asked to review Mr. Green, who's a 74-year-old gentleman on the orthopaedic ward. He's had a hip replacement and today he's been quite drowsy, so we decide to take an ABG. Looking at this ABG, we can see that the pH is low, which suggests the patient is acidotic. Looking at the PCO2, we can see that that's high. So, does the PCO2 match with the pH? Well, yes, it does, because a high PCO2, remember that PCO2 is acidic, a high PCO2 generating lots of acidity does match with a pH that's low, because it suggests that the PCO2, which is high, generating the acidity, is creating the low pH. What about the bicarbonate? The bicarbonate here is normal, and that suggests that there's no compensation. And that implies that this is an acute problem, because metabolic compensation, as provided by the bicarbonate, takes a bit of time to kick in. And finally, the PCO2 is normal, so the patient is not hypoxic. So this is a respiratory acidosis with no compensation. So what are some of the things that might cause a respiratory acidosis where the pH is low and the PCO2 is high? The main thing that causes a respiratory acidosis is anything that causes hypoventilation. So let's think about this. If you're hypoventilating or breathing slower, it means that you're not breathing out as much CO2. This means you're retaining CO2, and with lots of CO2 in the body, that means it can cause an acidosis from a respiratory cause, so it's a respiratory acidosis. Some of the things that might cause this include COPD, respiratory depression from overuse of opiates, muscle paralysis, such as from Guillain-Barré syndrome or motor neuron disease, chest wall deformities, if they cause hypoventilation, and iatrogenically, when we're ventilating patients if we're not ventilating them enough. One of the potential diagnoses in this case for Mr. Green's abnormal blood gas could be overuse of opiates following his hip replacement yesterday. So let's now look at another example. So Mrs. Blue is a 23-year-old lady. She comes to A&E and she's quite short of breath with low oxygen saturations of 87%. So as oxygen is being connected and prepared, we take an ABG. And looking at this ABG, we can see that the pH is high. Therefore, she's alkalotic. And now we need to work out, is it a metabolic alkalosis or a respiratory alkalosis? So looking at the PCO2 next, we can see that this is low. And does a low PCO2 match with this alkalosis? Yes, it does, because CO2 causes acidity normally, so if there's less CO2 around, that will cause the opposite and cause alkalinity, which matches with an alkaline pH. Next, looking at the bicarb, we can see that this is low. And therefore, as this low bicarbonate doesn't match with the pH, this suggests that it's metabolic compensation. So it suggests that this is a respiratory alkalosis with metabolic compensation. And looking at the PO2, this is low. Therefore, this patient is hypoxic, and this matches with her low oxygen saturations and that we took the ABG before oxygen was connected. So what are some of the causes for a respiratory alkalosis where the pH is high and the PCO2 is low? It's the opposite of respiratory acidosis, in that anything causing hyperventilation or breathing too quickly can cause a respiratory alkalosis. So if you're hyperventilating, you're breathing very fast and you're blowing off CO2. Therefore, there's less CO2 in the blood, and that results in a respiratory alkalosis. So some of the things that cause hyperventilation are things like anxiety, pain, a pulmonary embolism, a pneumothorax, and iatrogenically for us ventilating patients too quickly. In this scenario, we had a young woman who was breathless with low oxygen saturations. This suggests that she might have had a pulmonary embolism or a pneumothorax. It could have been anxiety, but anxiety wouldn't cause low oxygen saturations, so wouldn't match with the overall clinical picture. So let's now talk through another example. There's a 16-year-old girl, she has no past medical history, and she comes to the hospital with drowsiness and dehydration. So we do an ABG. And we can see in this ABG that the pH is low, so she's acidotic. And now we need to work out if this is a respiratory or a metabolic acidosis. The PCO2 is also low. Now, does this low PCO2 match with a low pH? No, it doesn't, because CO2 normally causes acidity, so if there's a low CO2, that's more consistent with alkalinity, which doesn't match with the pH. What about the bicarbonate? The bicarbonate here is low, and that does match with the pH, because there's less bicarbonate around to cause an alkalinity, so if there's less bicarbonate, we get acidity. Therefore, this is a metabolic acidosis with respiratory compensation, and the PCO2 is normal, so she's not hypoxic. So what are some of the things that might give you a metabolic acidosis, i.e. make you acidic from a metabolic viewpoint from ions in the body, which gives you a low pH and a low bicarbonate? So one of the things that can cause a metabolic acidosis is gaining lots of hydrogen ions, which we know are acidic. So this can be if you decide to eat acid for some reason, or if your body's making more acid than normal, for example, in lactic acidosis. Or you might be losing bicarbonate. So remember that bicarbonate usually gives us some alkalinity. So if you lose bicarbonate, you get acidity in the blood. And this can be from things like diarrhea. So one of the things that's important to know with a metabolic acidosis is the anion gap. The anion gap is the difference between the cations, the positive ions, which we tend to measure as sodium and potassium in the blood, and the anions, the negative ions, we measure chloride and bicarbonate in the blood. And this anion gap is important because it helps us with the diagnosis of the cause of the metabolic acidosis. So the normal anion gap is between 4 and 12 millimoles per litre, and on the left side of this slide here you can see some of the causes of a normal anion gap metabolic acidosis. And one of the commonest here is diarrhea, but can also be from things like renal tubular acidosis or Addison's disease. There are also some causes of raised anion gap metabolic acidosis, and the acronym to remember this is MUD piles. Looking at this acronym, we're unlikely to see people with a parahaldehyde overdose or an ethylene glycol overdose, which is antifreeze. But there are some common things that we might see for patients with a metabolic acidosis and a high anion gap, typically DKA, lactic acidosis, and a salicylate or aspirin overdose. So if we think back to example 3, the beginning of the scenario, if I told you that the patient had a high anion gap metabolic acidosis, and she presented, as we know, with dehydration and drowsiness, and she's a 16-year-old girl, what would our top differential be? Well, one of the things this could be that we don't want to miss is a diabetic ketoacidosis, and that fits with her age and with her symptoms. So what are some of the things that can cause a metabolic alkalosis with a high pH and a high bicarbonate? So the clue's in the name. It's an alkalosis caused by a metabolic cause, i.e. things to do with the balance of ions in the body. And it tends to be because of a loss of hydrogen ions rather than a gain of bicarbonate ions. And this can be gastrointestinal loss, which is commoner, or loss from the kidneys. So gastrointestinal loss of H+ ions, the commonest cause of this is vomiting, and this is what we saw with Mrs. Yellow's ABG. Or you can have renal loss of H+ ions, for example through certain types of diuretics, heart failure, or nephrotic syndrome. So to summarise, there are 4 main acid-base disturbances. You can have a respiratory acidosis, where you retain carbon dioxide, usually because of hypoventilation. You can have a respiratory alkalosis, where you blow off too much CO2, usually because of anything causing hyperventilation and causing you to breathe too quickly. You can have a metabolic acidosis, where you retain hydrogen ions and excrete bicarbonate ions, for example diarrhea, and in metabolic acidosis it's important to check the anion gap because this can point to a particular diagnosis, depending on whether the anion gap is high or normal. And finally, you can have a metabolic alkalosis, where you retain bicarbonate ions and excrete hydrogen ions, for example vomiting. It's really important to relate the acid-base disturbance back to the specific patient in front of you and use it as a tool in conjunction with the history, the examination and the general clinical picture of the patient to help with the diagnosis and management plan for that specific patient. Finally, here are the references I used and some useful sources. There's lots and lots of practice questions available on the internet and in multiple textbooks, which I would recommend you use to hone your ABG interpretation skills, as well as practicing on the wards where you can. Thank you so much for listening to this presentation. I really hope it was useful for you, and I'd like to wish you all the best of luck with your future ABG interpretation.